Okay, so we are a minute past the hour. We'll see if folks join over the next minute or so as I introduce our esteemed panelists. We've got Christy Musser here, who's the Senior Director of Virtual Care and Patient Experience at St. Luke's University Health Network. Jake Harper, who's an associate at Morgan & Lewis in Washington, D.C., an esteemed lawyer that I've worked a lot with in the Center for Telehealth Policy and e-law. And Frank Seitz, who has been a guest of ours on these webinars before because of his wonderful perspective on telehealth and virtual health in general. And he is the Enterprise VP, Emergency Room and Hospital Medicine Manager for the Connected Care operation. So glad to have everybody here. I'm Michelle Hager, Managing Partner of Luceris, but let's get jumping right into it because I know everybody wants to have a conversation about this. So quickly, we did do a webinar last month. It was kind of a precursor to this webinar, and it was just kind of introducing the topic of virtual first. And one of the things I wanted to note is I looked at some data, and when we look at virtual visits now post-pandemic, we know that at least some of the data that we've seen from Accenture from the federal space is even if they have an assertive growth of telehealth through to 2025, they look at it about 33% of projected uses of virtual visits versus more standard face-to-face medical appointments. And then conservative would be around 15%. So I know that there's some different data that we might have here on the panel, but just to kind of level set overall right now where we are. We know that primary care providers, we've said this over and over and over again in these webinars, the shortfall is going to be extreme. Not only are we not graduating, and now with the pandemic, we're also seeing an even smaller amount of providers overall, whether those are physicians or nurses or other advanced practice professionals not graduating out of healthcare. Even though we saw some folks joining, we see just as many kind of senior folks leaving because of the sort of mass resignation that we see happening across the country post-COVID. And then, of course, some major disruptors in the market with recent news that Amazon is buying the primary care provider One Medical. What are they going to be doing with this? I tend to be a little bit skeptical myself about these big splashes that big companies make, Walmart, Amazon, others, but it is something to consider. That was a huge deal to purchase those positions. And what are they trying to do as a logistics giant? They're trying to utilize what they do well and try to extend that into the healthcare space. Lots of big vendors have tried to sort of conquer healthcare, including Google and Microsoft and others, and have eventually fell out of that business. It's a tough one to turn into the standard business model that you would normally have. So from a question perspective, to all of my panelists, why should we even think about or consider a virtual first approach? And Jake, I'm going to let you go first.
Thanks very much, Michelle, and thanks for having me on. Yeah, no, it's certainly, as you said, it's a hard industry to break into, certainly for folks who are not part of it. And I think one of the main issues of that is the legal hurdles that are involved in healthcare, right? It's unique in the sense that it is a very ancient art and something that people take very seriously, including federal and state regulatory bodies. So, I always think that law should be a reflection, and it's not always the case, but law should be a reflection of policies that are best for governing sort of how we take care of people, right? And I think when you think about that, there's sort of four pillars now that I think of in terms of healthcare, right? There's sort of access, quality, cost, and then sort of the last one is provider burnout, or providers, how they're feeling about healthcare services and the delivery of them. And so, I think one of the things when we're thinking about virtual care services and the legal aspect of it is, how do we balance those four factors together to achieve sort of the greatest outcome for the greatest amount of people? And certainly we've been focused on access issues. There's always this cost issue that's sort of coming up and down, and trying to think about what the issue is there. But I think in terms of a virtual first aspect, there's a number of legal issues that come up, right? So establishing a physician patient relationship, right?
Mhm.
Can we do that through audio, video? Can we do that through audio? Can we do that through messaging, or just frankly, even an order for some kind of diagnostic service? And so that's sort of the biggest issue. And states have very, very complex and oftentimes rigorous and evolving rules when it comes to what the relationship between a physician and a patient should be like. And so while virtual first, I think, is a really effective way to be thinking about these kinds of services and delivering medicine, it can also be really complicated by the fact that there's a number of state laws that sometimes, frankly, are antiquated, that you have to work around. And so there's always this legal hurdle that exists even before we get to the clinical aspects that I think can be challenging in terms of anyone implementing something like this.
Heavily regulated. What are your thoughts, Christy?
I completely agree. My mind is always jumping to, oh, this is going to be great. It's going to work. But then you have to go
Stop.
through.
The lawyers, right?
Yeah.
Right.
Then it's like, oh crap, we have to, not crap. No, not crap. but we in the organization I work with, we've developed an excellent relationship with our legal team, in really working through some of those hurdles that, frankly, we never even thought of before this all started to happen, because we were just used to doing in-person care. So as we move to this new care delivery kind of concept, we're going to have to create new guardrails, regulations, and that's going to take time. So as much as I want to jump into this and do this right away, right, we do have to consider all that. But with that said, I think we are moving in this direction. I think it's where it's going to be. We're not going to stop it. So we have to figure out how to make it safe, effective and cost effective, and convenient, that access piece for patients. We can't underestimate how COVID really drove us into, if we thought consumerism was here before, it's really here now. COVID really propelled us into that. So
Huge. Absolutely.
Yeah. Yep.
I asked Frank to kind of play the devil's advocate role. So Frank, any thoughts on why we should even consider this, or why we might not?
I think Jake lined it up perfectly, because we have an ancient art of how we take care of patients. And, quite truthfully, we have the wrong comparators in how we look at telehealth versus in-person care. And I've shared with all of you in past, that to me is just an archaic way of looking at healthcare. It's, what is the right comparator isn't in person to virtual. It's virtual versus no care at all, or delayed care. And, if you have the right programs in your organization set up on, discussing your regulatory risk, legal compliance, you put the right education modules in place on how to train your providers on how to do an effective, physical exam virtually, you can get to what you need to get to. And really, what do we need to get to is the next actionable step. And having a virtual first approach allows you to figure out your next actionable step. And I've also shared with you, when I go to my doctor, I still had to go someplace else to get my chest x-ray. I still had to go someplace else to get my EKG or my labs. So, it kind of debunks that myth a little bit that you can't get what you necessarily need in a virtual first environment. But, clearly you have to do it the right way, because if you don't, you open up a Pandora's box of things that can go wrong that you're going to spend all of your time mitigating rather than actually taking care of patients.
Absolutely. Absolutely. So I'm going to skip past one question, because I think we have actually done a good job of covering it, and that's around the implications. So if I just share that question, whoops, I think I might just keep it on the side just to avoid that. Our next question is around, how do we think the commercial plans and the federal government will really react to this? One of the things I proposed in my precursor webinar is that commercial insurances could in fact incentivize their beneficiaries or their members to do a virtual visit first for non-complex care, in the same way that we see prescriptions being free if you choose generic brands, or lower cost if you choose generic brands, to do the same thing for these diagnoses. If you do our virtual visit first, it would be a less cost or no copay or whatever they could incentivize you around from a contract perspective. So what do you think the commercial insurances will do and the federal government will do around this? And I'll kind of go the opposite way. What do you think, Frank?
You know what? I'm the cynic of the group. So, take this all with a grain of salt that I'm from Philadelphia. We held the first national academic telehealth conference, in Philadelphia probably about 6 years ago or so. And we had the keynote speaker who is the president of a large insurer in our area. And we heard over and over again about how important virtual care was to the overall health of the patient. I could tell you that, 4 years went by until we had COVID and nothing was done on the payment front. Maybe the optimistic side of me says that, maybe people have learned and they're more willing and engaging to incentivize and engage patients in their own care virtually and really kind of put a quality approach for providers to give that care through telehealth and put a little bit of more of a light on that. If I thought I knew where it was 6-7 years ago, I surely don't entirely know where it is today.
It's a tough one right now. And Jake, what about from the legal perspective?
Yeah, no, I think it's very interesting. Obviously commercial insurers have a great deal of flexibility in sort of what they do and how they do it. Michelle, to your earlier point in presentation, right? I mean, there's a lot of ways that they could incentivize care, but as Frank knows, they perhaps haven't until they were forced to by some other external force. There's been a long history of this debate about coverage parity versus payment parity, and there's implications for that on both sides of virtual first. So, for instance, the idea that it's less costly, well, if there's payment parity and it's 100 to 100, it's really not less costly, right? And some states have tried to sort of build in this sort of maybe 70% or 50% or a floor to try and figure out a way to make telehealth a more economical kind of vehicle to deliver the same kind of care that a patient needs. But it's been all over the board. And frankly, those commercial insurers, even when they have those kinds of obligations, have worked hard to try and mitigate them or minimize them as much as possible. So I think that you have a lot of issues when it comes to the interaction between various state laws and how commercial insurers want to play that. If they see that there's meaningful ROI that comes from a virtual first option, they will incentivize that, as some plans have, right? But there are other situations where perhaps they don't see that as much, or they don't think that X, Y, or Z, or they want a narrow network and they don't want sort of anyone here. And that could impact, obviously, access to care. Certainly, I think one of the big issues that this entire issue brings up is sort of the continuity of care. And are you worried about sort of a fractured care system? If, frankly, folks are going to Jefferson and St. Luke's on the one hand, but there's other folks who are using just sort of, whatever the closest app is, and I'll just pull up a random doctor and I don't care that they know about me or don't know about me. So I think commercial insurers should be trying to think about that and what that means for their clinical ROI and ultimately their financial ROI. With respect to the federal government, obviously Medicare and certainly Medicaid programs, I think they're a little bit more hamstrung by the existing laws, and sort of they have to do what their relevant Congresses have instructed them to do, right? And so they don't have as much flexibility in this space to sort of do anything. At the same time, I think they're recognizing that virtual healthcare is a really efficient way in many situations to pay for care and get care to patients who either otherwise wouldn't have it or need it quickly or something like that. So I think that's coming, but I think it's going to be sort of Titanic in nature. It's going to take some time. Not that it's going to sink, but it's going to go very slow.
Good recovery.
Yeah, I think,
Go ahead, Christy.
You mentioned so many good things here. I'll try to unpack it a little bit, but we talked about Medicare, and what I find interesting is I feel like Medicare actually has worked to develop some services that are not that one for one. And I think to Frank's point is that we're trying to say that it's a one-for-one thing and compare it to each other, but really virtual care is an enhancement or an addition to our in-person care, right? It's creating a more robust.
Not supposed to say in addition to, right?
Yeah, not yeah, no, because that will freak out. So a more it's able to really enhance the whole care delivery and keep our patients healthier, and hopefully not into those situations where we're, in a very costly place for healthcare and the patient's not doing very well. But what's happened is that, Medicare created things like, I'll say, the interprofessional consult or the e-consult. Now think about that, right? We're sending people to specialists because that's how we get paid, is they have to go in person and see. But the numbers are staggering about how many patients don't actually need to see the specialist. The primary care, the specialist could talk to each other and actually work it out. We could then create more access for those who really need to get in. Medicare recognized that and started paying for that prior to anyone else. So I think they're on the right track. The thing is that they're still hamstrung in their fee-for-service mentality, and that's a problem. And providers, when they think about it, when we're thinking about payment parity and pushing that, it's because we're still in that fee-for-service mentality, and right. I got to get paid that. So we have to move our mentality to a quality, value system to really move the needle on this, because otherwise we're going to be nickel and diming these individual services. The fragmentation, if we thought we had a fragmented care system now in a fee-for-service world, and we just have all these things out there and we're just paying for individual transactions, we're just going to perpetuate that problem. So a lot of things we have to think about as we develop, which I've said is we see where we're going, but there's a lot of steps to get there, and there's a lot of players in it. And going back, Michelle, to that Amazon, if there's anyone that can figure this out, I think it's Amazon.
There are plenty of problems with Amazon. They can't solve all the problems in the world.
But I just want to say,
supplies fast.
Yeah, there you go. Jake. But Christy, one thing you raise a good point there, right? So I mean, I think CMS, to its credit, has really been focused on this value-based concept, right? That they've been working through for over a decade, really. Mm-hmm. I mean, think about ACOs that came out as part of the Affordable Care Act. I mean, even before that, they had other iterations of that. But I think the federal government sort of recognized that this concept of value and trying to avoid this sort of, we need to do all these different kinds of things, is happening. But it's going to happen very slowly, not because they're moving slowly, but I think because, to your point, the provider community doesn't always want that. The folks who are sort of in value-based care models and are really good at it, they're loving it. They're making a boatload of money and it's fantastic. But for your sort of average Joe down the street, that's not really that appealing. And there's sort of these incremental penalties that CMS is trying to add on to Medicare payments over time to sort of push them in that direction nicely, while avoiding them talking to their congressman about how horrible CMS is. But so that's gonna, but it's obviously this slow pull to get everyone on board on that. I agree. I mean, I think value-based care, we know it's the future. We've recognized and we have the data now at this point to support how important that is. But it's going to be a slog to get everyone on board to start thinking that way.
Definitely.
Telehealth is a component of it, though, and an important one.
Yeah, it's a tough one, I think, with the value-based, I know it's great for telehealth to be part of that, but it is really tough. You just said it really well, Jake, but it's really tough for those individual clinics and physician offices to sort of go away from a fee for service, because that is how they are being paid. And that is how they are managing their business. And as a business owner myself, that's what you're going to do.
Living on the edge is no fun.
Right. You
Yes.
have to make payroll, right? So they have to go and do what they need to do. But what about, this is something that I know is near and dear to your heart, Frank, about, how do we train staff so that we have the same quality of care? And we don't sort of create an inequity and one service is less than the other.
Yeah. So, I mean, we've approached this in our organization that telehealth is just another mode, right? It's just another way that we're providing our healthcare. And we've really worked hard not to, as best we can, allow wedges get divided between, virtual and in person. And, when we look at our policies, we look at the same quality metrics and the same, items that we need to ensure that people are getting safe, effective access to their care. What we did, which I think was a little bit unique, was we developed a quality and process improvement nurse manager position, which is an advanced practitioner, nurse practitioner in the organization, where it's her role to really work on improving quality and safety, interacting with each of our 18 hospitals, interacting with each of the quality directors and vice presidents across the enterprise to look at the care that we're providing, how we're providing it, what's our patient and our provider experience, and what's our satisfaction with that. And we've gone after a lot of different nuances about how it is that we provide that care. I said this before, bad care is bad care. And if we have bad care, we have processes for that. And it's called a PI process or a root cause analysis or an FMEA. And that's no different in telehealth. And on occasion, we tend to find that, something didn't happen or someone didn't document something or a patient got the wrong information potentially. And we have a process, and we go back and we meet with the people that took care of that patient, just like we would if it was an in-person care. We break it down. We do it in a way that's not judgmental, in a way that's focused on education and improving, learning from whatever happened, and making sure that we put processes in place, whether they're technical processes, whether it's educational or some other means, to avoid that from happening to another patient or occurring again. So, this is a process that we've really kind of done over time. And you touched on, the passion about the education of it. We've spent countless hours developing modules that people have to go through there. When they are credentialed, they have to attest that they've taken all the educational modules, and there's 4 of them really. I mean, it's regulatory risk, legal compliance type of things. And then we created modules on how to actually conduct an effective clinical exam. So those are the things that we put in place as a standard and as a baseline, that we think that we were pretty unique up front with that. And now we're at a point where we want to revise them. We're revising a lot of things. So those are the things I think you have to put in place to ensure quality and safety. And you have to give it the same rigor you would in-person care.
Absolutely. I just want to add to that. I know there's been a publication out there around the work that Intermountain has done. And as an academic facility like Jefferson, but Intermountain's work has been around reducing PTSD with clinicians, because they're able to do some education and train staff, and they really feel that they've been able to, do what was right for the patient in these areas where they may not normally see patients that are, tragically ill or have had a terrible situation, like in the case of, a neonatal patient that has a terrible potential outcome there, and maternal potential outcomes there in particular. So you can Google that. Christy, I'm interested to know what St. Luke's does in terms of training their staff as well in this space, and what is it that you feel like is working well?
So I first have to give a plug out to Jefferson, because at the beginning of COVID, one of our staff, we put through a course that you had made available to the public, and she still relies on a lot of that material and information. So it really did, and it got us thinking about, okay, what kind of curriculum are we going to develop? And we had to throw this stuff out there for COVID, but now we're saying, wait a second, there's a lot of things that we need to talk about outside of just the medical care itself, the process of how to help providers look at warning signs of when we need to escalate care, or when to stop the virtual care visit, right? How to troubleshoot technology, just multiple things. And then we have to look at it differently. The staff that we're going to need to support this is going to be different. So creating modules, creating scenarios where providers can learn and really build their skills. This is a new skill set for them. It has to be done if we want to ensure the same quality. They do this for medical school. We're actually introducing it into our residency program,
right?
And into our nursing school. So, we're really hoping to start it early and prepare them for what's coming. So, we again are partnering with some various institutions on building curriculum, and also, it's going to be continually evolving and changing. the medical exam piece, I think, is also important, and was just doing some research. It's important that we look at how to do an effective exam in a virtual visit when it's a little bit different, and you may have to have the patient do some things that you would normally do when you're with them. And we need to put the process of developing that through the same rigor that we would a regular, in-person medical exam. And there's one for neurology is put out for neurosurgery. There's a couple out there for, shoulder and more musculoskeletal kinds of exams. But we're going to have to do more research and testing and just a lot around a development around that to build up and make sure that we've got the quality as we provide services.
Yeah, absolutely. And I know all of us that have worked in hospitals and health systems over the years, Jake, we've all gone through the required compliance training. And so what is your suggestion in terms of, additions into the legal and compliance training that organizations may have if they decide to go forward with, a big virtual program? Or what small?
No, absolutely. I mean, I think one of the things that's important, and we kind of have not discussed it fully here, is sort of what virtual care and telehealth look like right now from an outsider's perspective. Because I think, it's obviously the COVID pandemic has really changed what the public opinion and the regulatory opinion is of telehealth care. I think one of the main issues that we all need to think about is obviously everyone in this room and sort of at large organizations, when you're talking about conducting an exam and how to sort of do that, that's fantastic, right? And sort of, and as Frank said, the standard of care is the same, so make it the same. That all makes sense. I think the issue that we have, though, is that organizations like these are also lumped into other kinds of telehealth programs. And there's this other cottage industry that, for better or for worse, is kind of doing these, press the button exams. Mm-hmm. And so when you're thinking about telehealth, and it's not that you can sort of be at the same level, you actually have to be higher at a better level of care, because frankly,
that's fighting words right there, but go ahead, Jake.
Well, no, because I don't want to do hot takes here, but there's a level of scrutiny on telehealth right now that, for better or for worse, fair or unfair, exists, right? Both from the public and from sort of the governmental standpoint. So I think that state medical boards, state pharmacy boards, state nursing boards, DOJ, OIG, CMS, you name it, right? They're walking into a telehealth scenario with sort of their guns up, right? Mm-hmm. Because they're thinking that there's probably something wrong here, that there's an issue clinically. Obviously, we've seen a lot of fraud situations. I'm not suggesting that is something that needs to be built into sort of a training program, but I think the recognition of where telehealth as a global industry sits right now is really important when you're training folks, because it's not enough to sort of, meet the bare elements. I think you really need to go above and beyond, frankly, right now, and show the value that this particular service provides, right? Mm-hmm. Because there's a lot of folks that are associated in the telehealth world where the level of care is pretty low. And right. So I think that's a hard area to balance, but and I did say that right at the end of the presentation, so we
so no one can say anything bad about it.
That's right. But no, I mean, I think that's just the reality that we live in right now. Mm-hmm. And so organizations that are obviously wanting to do this level of care, I think just need to understand the pond that they play in.
Right. I think it's an important point. It's not mm-hmm. something that we like in the telehealth industry, that there's some question around, fraud, and unfortunately the level of investment that has happened in this industry, I think, has has exacerbated the concern about that. So I think it's an important point. This has been a lively discussion. As we expected, we're right on time, but we do have a question from a friend of I think all of our panelists. Miss Yarbo has got a question here in the chat and asked about that the new AMA guidelines emphasis is on time and MDM, yes, and not so much PE. What are your thoughts then related to that as far as in-person, all headed to virtual, question mark?
It sure made it easier for virtual to be done, right? Because it took out that you have to complete XYZ of, of the exam, so many components and all that stuff. So it really did make it easier for a virtual visit to be done compliantly from a documentation and reimbursement standpoint as we look at the reimbursement environment right now.
What do you think about, though, on sort of the times, right? Because I think that in the AMA guidance, the times are really high.
The
right?
times went up. The times went up from what they were.
Is that feasible, though? I mean, that's sort of the one issue I always wonder about these things. When you base things on time, to get to a 99213, you're spending a pretty serious amount of time with a patient already. Right?
I think the difference there in the counterbalance to that is that it's time or medical decision making. And so you could actually do a higher level of medical decision making in a lower amount of time, and you're not bound to both. You're bound to one or the other. So you could choose, if you can document medical decision making but you didn't spend as much time, you're going to code that level based on the medical decision making. So that's kind of the check and balance there, because sometimes it's not such a big issue, but the patient wants to talk and work through something. So you're taking more time, but the medical decision making probably isn't there, but you still want to get credit for your time in that situation. Right. So it's a check and balance. I'm really happy with the changes. It went to outpatient last year. This year we're into inpatient code. So it's been a huge change. It's been a long time coming, and I'm super excited for it.
Any last thoughts there, Frank?
I think Carol had something about all virtual. I don't think it's going to be all virtual. So I think, again, I think that, I've heard conversations often that, we can't do everything on telehealth yet. March 21st of 2020, we were able to do everything on telehealth magically. But I don't think that that's the right way to provide care. Yeah. I think it needs to be complementary. I think it needs to be assessed in what meets the needs for the patient. We can achieve different things different ways, and I think complementary is the key.
That's a good finish there. Thank you so much. We are a little bit over time. I put in the chat to, if you want to come back and listen to this presentation again, you can look at it and listen to it on bluecirrus.com. Also, let us know if you have any topics that you want us to cover. We are happy to take those on, and whether that's anything from reimbursement and coding to compliance to workflow and redesigning your programs in general, or vendor selections. I am so grateful to this panel. You guys are rock stars in the industry. I really appreciate it. I know Frank, you've done several of these, as well as you, Christy, and Jake. Thanks for joining us today. It's been great to have you in this panel. Thanks so much.
Thanks.
And thanks for everybody for attending as well.
Thanks, everyone.
Take care.